Okay, I already start. You just look at the camera directly.
Turning my computer off too.
Right.
Hello, I'm Will Lee, Professor of Medicine at UT Southwestern, and for the next 25 minutes I'll talk to you about acute liver failure in 2017 with some emphasis on hepatitis B related acute liver failure. The definition for acute liver failure is that a patient has an acute illness affecting the liver that causes encephalopathy, altered mentation, as well as coagulopathy, usually measured by a PT-INR of greater than 1.5. This is a very severe form of disease with a high morbidity and mortality that affects approximately 2,000 people in the US, so it's really quite rare. Survival pre-transplant was very poor, and even now is around 60 to 70%. These patients get the highest rating in the transplant system in the US called UNOS, so that they are ahead of anyone else with cirrhosis because they're estimated to die in less than 7 days. It's a rare condition, frustrating to study because there are so few patients, and hard to treat. But as a result, we've put together an acute liver failure study group network in the US involving 15 to 20 sites around the US that collects data on this rare condition. This is an autopsy sample, slide 3, showing virtually no remaining hepatocytes in a patient that died after several episodes of halothane anesthesia, showing how severe the liver injury can be. So acute liver failure results from slide 4, from a variety of different conditions, including autoimmune hepatitis, hepatitis B, hepatitis A, and acetaminophen poisoning, as well as several others. Again, the main features clinically are onset of altered mentation, coma if you will, and coagulopathy, but there also is low blood pressure, sometimes bleeding, infection, and kidney failure. Why this comes on in such a rapid and often severe form is not clear, but it obviously involves necrosis of hepatocytes, a cytokine storm, lots of very high levels of cytokines in the circulation. And the causes, or the results rather, the effects of this include cerebral edema and poor ability to regenerate hepatocytes. As I mentioned a moment ago, the Acute Liver Failure Study Group is based at UT Southwestern and began 20 years ago to collect cases of this rare condition. So far we've got more than 2,000 cases in the adult registry and over 1,000 in a pediatric registry. We tend to collect detailed clinical data as well as biosamples, and have done a number of ancillary studies looking at specific diseases like hepatitis B in this patient population, and we have funding from the National Institutes of Health for this. Next slide. In this slide you can see that these are the various etiologies and the frequency of these etiologies over nearly 20 years of study. The most common cause on the far left is acetaminophen overdose, and I'll talk a little bit more about that in some following slides. Idiosyncratic drug reactions such as isoniazid also can cause acute liver failure, and again in this series we had 123 cases. About 7% of our cases were due to hepatitis B. This is a portrait of what the blood tests and the clinical scenario looks like in the various different etiologies. You'll see on the far left is APAP or acetaminophen. Next column is idiosyncratic drugs. And in the fourth column is hepatitis A and hepatitis B. What you can see is that for the drug-induced forms, the acetaminophen and idiosyncratic drugs, most of the patients are women, whereas in hepatitis, it's about 50-50 distribution between men and women. Again, the acetaminophen cases have a very short period from jaundice to encephalopathy at 0 or 1 day perhaps, whereas the idiosyncratic DILI and the viral hepatitis are more subacute. They take a week or more to evolve. You notice the difference in the ALTs, the aminotransferase levels, with the acetaminophen cases being the highest and the viral hepatitis cases being next highest, again with hepatitis B being somewhat lower than hepatitis A. Similarly, the bilirubin levels in the hyperacute acetaminophen cases are quite low, whereas those in the drug cases or the viral hepatitis cases are higher. And again, the outcomes differ according to the different etiologies, with spontaneous survival, that is without transplant, being more favorable in those with acetaminophen toxicity than in idiosyncratic drugs or hepatitis B. On the next slide, I'm going to talk a little bit about acetaminophen. This is an autopsy section from a young girl who died after an acetaminophen overdose, having cerebral edema. And what you see is central lobular necrosis. The central part of the lobule is where the injury is most prominent. If you look at what the clinical scenario is, the things that impact survival are largely those related to multi-organ failure. Specifically, these patients can develop cerebral edema. Unclear exactly how this develops, but it's quite important in terms of as a cause of death. Many patients have renal dysfunction. They all have coagulopathy and sometimes have lung or cardiac abnormalities as well. The main distinctions one should make early on is to try to figure out what the specific etiology or diagnosis is for this kind of ALF. Specifically, is there a history of acetaminophen or use of other prescription drugs? Is there any evidence for mushroom use? Is there any evidence for Wilson's disease, and so forth? The viral serology tests can be used to sort out whether the patient might have hepatitis A or hepatitis B. Again, you want to see how sick the patient is, and this involves determining the coma grade, what their blood pressures are, obviously, and following them closely because they can deteriorate very rapidly, even over 12 or 24 hours. If you have access to transplantation, it's a good idea, if you're concerned, to get them to the transplant center early on rather than waiting till they're too sick and require intubation. Typically, we will intubate patients and begin to breathe for them and protect their airway when the coma grade goes from grade 2, where they're altered but not fully asleep, to grade 3, where they're pretty much unarousable. Transplantation can be used in this setting and is frequently used, again depending on the severity of the disease in the individual patient and what the prognosis is for that specific etiology. For example, on this slide, you see that acetaminophen has a good prognosis, with 2/3 of patients recovering without needing a transplant. Still, about 30% of patients die, and only a small fraction receive a liver donor organ. Similarly, if you have a liver injury and acute liver failure due to ischemia or hypoxia, either shock liver or poor oxygenation to the liver, you will have very high enzymes like acetaminophen, but you will have a rapid recovery once the circulation is restored. Pregnancy and hepatitis A also have pretty good outcomes without requiring transplantation. However, idiosyncratic drugs, hepatitis B, autoimmune, and Wilson disease all do quite poorly. There is a small group of patients with indeterminate related ALF, and that means we don't know the cause, and we're still looking for why these patients are affected in such a severe way. So there have been a number of therapies used in the past. I've listed them here and I won't go over them all. Most of them are not of much help, and there is no liver support machine or liver transplantation or cell-based transplantation system currently operating. One thing we have used to try to help patients with acute liver failure is N-acetylcysteine. This is the very successful antidote for early presentation of acetaminophen overdoses, but is not thought to be much effective in patients later on in their disease with acetaminophen overdose. However, we tried to use this medication in patients without acetaminophen overdose, such as hepatitis B or autoimmune hepatitis. And as you can see in this bar graph, although we didn't seem to improve overall survival, the transplant-free survival was improved in the patients in blue that received the NAC, the N-acetylcysteine IV infusion. The effect was most pronounced, as you can see in the columns in the middle of the slide, in those patients who had early coma grades, that is, coma grade 1 or 2. We've done a look-back study over the past year or so at this first 16 years of our acute liver failure study group study. And just to summarize this very quickly, this article was published in Annals of Internal Medicine in April of last year. There were no differences overall over the 20 or 16 years rather in the disease severity or in the different etiologies that we saw. However, we did over the 16-year period see improvement in the outcomes, fewer patients requiring transplantation, and interestingly enough, less use of intensive care support measures such as ventilation, blood products, or vasopressors. Now let's turn for the remaining minutes to a quick discussion of HBV-related ALF. If a patient gets acute hepatitis B, only a small fraction, perhaps 1%, get acute liver failure from this, but they do tend to have fairly poor outcomes. What we think this represents is overimmune response and overexuberant immune response that leads to smashing most of the liver cells all at once. Whether this is antibody mediated or has to do with plasma cells, we think it does. And that these patients may require transplantation. There's a second form that we're seeing in the US as well, which is reactivation, and this is of course seen in Asia too. Reactivation of inactive hepatitis B in the setting of receiving immunosuppression, such as chemotherapy for breast cancer or lymphoma. So in the subsequent slides, and I'll go through these very quickly, we looked at the immunohistochemical staining of patients that received a liver transplant, where we had the organ available to subsequently to stain. In this first case I'll show you, there's virtually no remaining hepatocytes seen in this low power view and even in the higher power view that I showed first. If you stain for surface antigen, there was essentially no surface antigen. All the cells have been necrosed, and there's virtually no remaining viable cells and no surface antigen seen, interestingly enough, nor is there any core antigen. In other cases, however, where there is more remaining tissue and the liver is less severely affected, as shown here, the cells look somewhat sick, but at least there are still many viable cells seen. You can see intensive staining for surface antigen, seen here as red in the cytoplasm of hepatocytes, and for core antigen also seen in the nuclei of the cells. And again, this second case was a case of Hep B reactivation. Again, here's I don't have time to go on and show you any more. So in summary, acute liver failure is a superorphan disease. It's very, very rare and requires specialty care. Transplantation can be a successful option for these patients. We do tend to give them N-acetylcysteine both for acetaminophen cases and for non-acetaminophen cases. We're trying to figure out more carefully how to predict who's going to require a transplant and who will recover spontaneously. Thank you very much for your attention.